All right, recording has started. Today we'll be beginning our EMS Con Ed with module number 1. I currently have Bergbaum, Owen, Petrosino, Phillips, Rohn, Tackett, Vollmer, and Van Adema present at this presentation. And our first module will be baseline vital signs and sample history. If anybody has any questions as we go, you can raise your hand using the icon at the bottom of the participant window, and I will acknowledge the fact you raised your hand, and I'll stop my lecture and ask if you have a question. If you want to send me a text question, that's fine. You can use the chat window to send a text question, and I'll glance at that from time to time. But basically, we're going to start. These are the cognitive objectives that we're going to be covering. Vital signs, how to obtain breathing rate, attributes attained when assessed breathing, differentiate between shallow and labored breathing, and describe the methods to obtain pulse. Also, information obtained when we're assessing a person's pulse, differentiate between strong, weak, regular, and irregular, and then assess skin color, temp, condition, cap, refill, and then normal, abnormal skin colors, pale blue, red, and yellow skin color, normal temperatures, differentiate between hot and cold skin temperature, and abnormal conditions. And then we're going to be talking about abnormal cap refill in children, assessing pupils, pupil size, constricted, dilated, what that means, reactive and non-reactive. And then going on and describing blood pressure, how to assess it, the difference between what a systolic is, diastolic, and then explain between auscultation, palpation on blood pressure. Okay, talking about sample history, we're going to differentiate between what a sign and a symptom is and how we report and record the baseline vital signs and searching for additional medical information. What the value is for baseline vital signs, and we're going to recognize and respond to the feelings patients experience during the assessment and defend the need for obtaining and recording an accurate set of vital signs. And moving on, these are some other additional objectives. Psychomotor skills, the skills involved in assessing breathing, obtaining a pulse, measuring skin condition, temp, cap refill, and assessing pupils. And then psychomotor objectives would be how to obtain a blood pressure, both auscultating and palpating, and the skills that should be used to obtain information from the family or the patient and bystanders. And pulse oximetry, we'll be talking a little bit about that. Okay, our baseline vital signs we do on pretty much every single medical call that we run. Pretty much EMS leaves it up to us to handle the vital signs, so they're counting on us to do a good job in accurately gathering that information. We will evaluate the patient. We want to learn what the history of the patient is, and we want to learn about the patient's overall health. Let me go back. Part of evaluating the patient would be we obtain the person's full name. We want to know how old they are, gender, race. When you address children, how do you talk to children generally? Do you talk to them by you just try to find the child's first name and talk to them using the first name. If a patient's disoriented or unconscious, what's the best? Somebody give me how you would find out their key information about them. Jeff.
Look in their wallet.
Look in their wallet. Look for their driver's license or other form of identification.
Anybody around that knows them.
Yeah, one thing you want to make sure, though, is that when you're doing it, that you have somebody around you that's doing it, so that there's always someone present in case there's a valuable or something like that in the wallet. You don't want to be accused of theft. Learn the history of the patient. Learn about the patient's overall health. Baseline vital signs. Basically, gathering key information, obtain their name, age, gender, race. Look for ID if the patient's unconscious. Chief complaint. You're looking for a major sign or symptom reported by the patient, and that's going to be first person information. And then bystanders or family, you can get information from them. Symptoms are typically problems or feelings a patient reports. Typically, a symptom is subjective information. It's something that there's a lot of latitude. When they give you a symptom, they're giving you subjective information that hasn't been substantiated by any fact or any kind of sign. Now, sign is the opposite. Sign is something that can be seen, heard, felt, smelled, or measured. It's something that's more concrete than a symptom. A symptom is something that they describe to you. Obtaining sample history. Sample, we'll go over it. Signs and symptoms. What signs and symptoms occurred at onset? Allergies. Is the patient allergic to medications, food, or other things? And then medications would be what medications the patient is taking. And then P stands for pertinent past history. Does the patient have any medical history? Last oral intake. When did the patient last eat or drink? And then events leading to or injury or illness. What events led to this incident? It's really important in regards to doing the sample history that you try to have a systematic way of doing this, and you should try to use that as much as possible, the sample history. Let me go ahead and let's watch a short video on physical exam and sample history. I'm going to go ahead and launch the video, and when we're done, we'll get back to the PowerPoint. And send me a text message if you don't get the video. It's going to take a second to load up. Everybody's going to load up at a different pace. Is the video loading for everybody?
Victims with a significant mechanism of injury often need a physical examination.
Oh, disregard that dots thing. That's old. This is an old video. It'll get into some newer stuff later on. Just the focus on this exam is how to do the physical exam. This video is just giving you a way of doing a physical exam quickly. Give me a check mark when the video is completed. The green check mark when the video is completed. Okay, I'm back. Nate, did yours finish? It should have. Okay, good. All right, so that kind of, the most important thing on that video was just going over the sample, and they just did a quick physical exam head to toe. On patients, whether they're trauma or medical, always a sample should always be done, regardless of whether it's a trauma or a medical patient. The next thing we're going to deal with is OPQRST. The only time or when you typically would use the OPQRST mnemonic is when the patient is experiencing or is expressing some form of pain. And this is a conscious patient. You can't do an OPQRST if someone is unconscious. You can do a sample if someone is unconscious, maybe by using a bystander. You can get information, obtain information from them using a sample if someone is unconscious. But if someone is conscious, you can do the OPQRST, going through onset, when the problem first started, provoking factors, what creates or makes the problem worse, quality of pain, description of the pain, and then moving on. Next thing would be region and radiation of pain or discomfort. Radiation would be considered any additional area where the pain or discomfort may also be present. Ask the patient to point to the area of pain, describe the area of pain, or describe pain anywhere else associated with the problem. Describe the region of the pain. In other words, is it focal pain? In other words, is the pain in a single place? Is it diffuse pain, which pain is in an area instead of a single location? And the best way to ask about radiation is you want to say, do you have pain or discomfort anywhere else, is how you want to ask about pain. And then the severity is the next one. The patient's perception of how bad the current episode of pain or discomfort is compared to others. Questions to ask to assess the severity would be, how bad is this episode in comparison to any previous ones that you may have had? What happened the last time you had an episode of pain that was this bad? And then the other thing would be, how would you rate this pain in numbers? In other words, is 1 is considered normal and 10 is the worst pain or discomfort you can imagine. You want to give them a scale of 1 to 10 in regards to the pain. So you have questions to assess the severity would be, this particular episode compared to previous incidents of pain, and then what happened last time you had an incident this bad, and then what's the severity of it in regards to a scale of 1 to 10. And the next one is time and treatment. In time would be, you want to ask about the previous time the patient experienced the problem and what the treatment they tried and did it work. And then ask if the problem is constant or intermittent in regards to time. Okay, next thing we want to get into is baseline vital signs. And on the initial assessment is a rapid evaluation of the patient's general condition to identify any potentially life-threatening conditions. Repeated vital signs will be compared to the baseline vital signs. And then vital signs will always include the respirations, the pulse, and the blood pressure. Other key indicators that we're going to use are skin temp and condition in adults, and then capillary refill time in children, and pupils and LOC in level of consciousness. Okay? The first vital sign that we're going to evaluate would be considered respirations. A patient who's breathing on their own and it is said to have spontaneous respirations. Each complete breath includes 2 phases. You have your inspiration and the expiration. The inspiration is when the chest rises up and outward. That's when oxygenated blood is drawn into the lungs. And then the expiration is the chest falls back to its original position. Air with increased CO2 is blown off the lungs. EMS has a device when they hook it up to their endotracheal tube. It measures the amount of expired CO2. It's an end-tidal CO2 detector. The active inhalation phase lasts about 1/3 of the time that the passive exhalation phase happens. Breathing is normally spontaneous. It's an automatic process, and it occurs without thought or effort. And there is sounds or pain when someone breathes if they're having a problem. How you would assess breathing would be by observing the patient's chest rise and fall, and then you'd feel the air being expelled and listen to breath sounds with the stethoscope. The chest rise and breath sounds should be equal on both sides. When assessing respirations, you want to determine the rate and quality and the depth. And then the rate is when we time the respirations, count the number of breaths, and typically we're going to use a 30-second window, and then we're going to multiply by 2. You want to check respirations in a conscious alert patient without making them aware that they're being evaluated. We always know that. And the ranges for adults are 12 to 20, children are 15 to 30, and infants are 25 to 50. So there's a difference based on the age of the person. Adults generally breathe slower, then children a little bit faster, 15 to 30, and infants are always fast breathers. The quality, you want to determine the quality and or the character of the patient's breathing while assessing the rate. And let me hold on for 1 second. We had some people drop off the screen. Who just dropped off the screen? Oh, Van's back on. Van, we had you drop off the screen and come back on. Is there a problem over at 1?
No, just the screensaver popped up.
Oh, okay. Jeff, you got one? Hello?
Lost your audio. What'd you say there?
Okay, can you guys hear me?
Yeah, we can hear you.
Okay. All right. Moving on, here's the respiratory rates, 12 to 20, 15 to 30, 25 to 50. Okay. But let me go back on respirations. We're dealing with pulse oximetry. Let me see. We jumped ahead here. Basically, pulse oximetry, which we have in our truck, evaluates the effectiveness of oxygenation. Basically, the probe is placed on a person's finger. One thing you want to make sure is that the fingernail does not have fingernail polish on it. This is a tool that's just assessing whether or not the person is effectively breathing, but it doesn't replace good assessment. In other words, good assessment they mean by listening to all the lung fields to make sure that they're adequately moving air. Sometimes you can get patients that are making the motion of moving air, but they're not moving adequate supply of air. If they are making attempts to breathe, but there's no air that's going in and out, pulse oximetry is generally going to read below 85. You know, but that's not. You can't just use pulse oximetry to determine whether someone is oxygenating himself well enough. This is just showing the different types of pulses we take. The two most reliable pulses that we take would be a radial pulse and a carotid pulse. Yeah, let me move on. Let me go back to pulse oximetry, cover a couple things. In most, whoops.
Hey, Cap, can you go back a couple slides?
Yep.
Yeah, right there.
Okay, go ahead.
Okay, that's
Question?
good. Nope.
Okay.
We're good. We're good.
All right. Okay, so the first vital sign would be considered respirations. Anybody have any questions about assessing respirations on patients? Let me just go over a couple things on respirations that hasn't been covered. The effort someone breathes. Normal breathing is considered effortless, and then speaking is a good indication of whether a person's having difficulty breathing. A good example would be if someone can only speak one word at a time, and they have to stop to catch their breath. That gives you an idea that they're working really hard at breathing. Okay, so that would be considered someone having difficulty breathing. A patient who's in the sniffing position, sitting upright, with the head and chest thrust forward, and making a significant marked effort to breathe would be someone having difficulty breathing. The next thing would be, as far as breathing, that would be considered that's described as labored breathing. Initially, labored breathing is characterized by a patient's position, concentration on breathing, and increased effort in breathing with each breath. What happens then eventually is that you start seeing accessory muscles being used. Their shoulders will start to flail a little bit. You'll see retraction in the neck, and that's serious labored breathing. Sometimes you'll hear grunting sounds. When stuff like that happens, you need to take action and start doing assisted ventilations. Nasal flaring is something more that you're going to see with children and infants, and that's a sign of labored breathing. The patient could be gasping. Kids will become exhausted and no longer have the strength to breathe. And then in infants, generally what happens is they'll have respiratory arrest first. Generally, cardiac arrest is caused by respiratory arrest. And then basically any questions. Depth of breathing, the amount of air the patient is exchanging depends on both rate and respirations and tidal volume. The depth determines whether tidal volume is normal, less than normal, or greater than normal, and it goes on. You have shallow and deep breaths based on the respiratory rate. Okay, we're done with respiratory. That's the first vital sign. Pulse oximetry, just to review, measures oxygen saturation in the capillary field. Most patients normal would be considered 98 to 100%. It's a tool, but it's not to replace good patient assessment of the airway. Several conditions give false readings. Would be, somebody give me an example of what a false reading would be with the pulse oximetry. Anybody know? Off the top of your head? You're going to get a patient, you put it on, and all of a sudden it reads 100%. And what would give you a false reading? And they're having difficulty breathing, serious difficulty breathing. Does anybody know? Okay, I'll give you 4 conditions. Hypoperfusion, in other words, they're got horrible blood pressure. They're not perfusing. Their body is shutting down. They're not perfusing to the extremities. You're going to get a low pulse oximetry reading. Hypothermia, also the system is shutting down. That's another where you're going to get false values. And then bleeding, anemia, and then carbon monoxide. Carbon monoxide exposure, you're going to get real high pulse oximetry readings with carbon monoxide exposure. They're going to still have difficulty breathing, but typically their pulse oximetry could read 100, but they're struggling because of the affinity of the CO to the hemoglobin. All right, pulse. The second vital sign is a pulse. What a pulse is, it's a wave, a pressure wave, which measures the heartbeat. We all know that. We palpate for a pulse, 2 fingers, and we use 2 points. We use the carotid and we use the radial, or 2 indications. In responsive patients who are older than 1 year, the pulse is commonly palpated at the wrist, where the radial pulse can be palpated, easily located. In unresponsive patients older than 1 year, palpate the carotid pulse in the neck. Go ahead. This is where you do a pulse on an infant would be the brachial, and then the pulse rate. You can count either 10, 15, 30 times 2, times 10 would be times 6, 15 times 4, 30 times 2. You want to measure the strength, bounding, strong or weak, regularity, irregular. Normal ranges would be 60 to 100 beats, 70 to 150, and 100 to 160. And then we get into skin color. Pink, pale, blue, red, or yellow. What's an indication? Somebody tell me, if you see someone that's yellow skinned, what would you think of right away?
Liver problems. Sure.
Liver failure, jaundiced liver failure. What about an infant? That's jaundiced.
Jaundice.
Okay. Blue, someone who's blue or ashen color.
Not enough air. Not enough oxygen.
Not enough oxygen. And then pink,
Ashy.
someone who's pink.
The carbon monoxide.
Carbon monoxide, exactly. Then you got your temperature, warm, hot, or cool, and then moisture, dry, moist, or wet. How do we measure if someone's dehydrated?
Again, sometimes their skin gets wrinkly.
Gets wrinkly or gets tinting that starts?
Yeah.
Correct. Okay, cap refill, what it does is evaluates the ability of the circulatory system to restore blood to the capillary system, tested by depressing the patient's fingertip and looking for blood return. How quickly does that return have to happen for them to be considered normal?
Seconds.
2 seconds or less. This is only reliable on children, children under the age of 6. Let's go ahead and go over a video on auscultating let's go over scene size up an assessment video. We're going to watch a video. When we're done with the video, go ahead and hit the green check box and let me know that you're done with the video. Okay, I'm back. Sorry about that. Okay, anybody have any questions about the video? Did everybody see the video? Was it okay? Well,
It was fine.
hold on a second.
There are 5 basic parts to patient.
Okay, I'm still here. Sorry about that. Hold on. Video's still trying to run. I'm going to shut it off. Okay. Okay, everybody, was the video good? Thumbs up or bad thumbs down? Okay, that's good. Everybody liked the video? Okay. All right, good. All right, moving on. Cap refill, we covered that. Any questions on it? Moving next, blood pressure. Okay, blood pressure is the next vital sign they're going to be looking at. Blood pressure is a vital sign. A drop in blood pressure may indicate a lot of things. Loss of blood, loss of vascular tone. You got a problem with the pump. It's not pumping properly. Blood pressure should be measured in all patients older than 3 years. It's so difficult to measure blood pressure in little kids. We carry currently, I'm sure, do we carry pediatric cuffs on the units? I'm sure we do. Yes? Okay, good. And then we should carry an extra large cuff for the big people. And then we should carry just a regular standard cuff. When any of the preceding conditions occurs, there's a small drop in circulation the body can attempt to maintain normal blood pressure by. What happens? The body will shunt blood away from the skin. It'll increase the pulse rate, or it'll constrict the arteries. So when you start seeing a drop in blood pressure, the body's going to try to compensate. And basically shunting, increasing the heart rate, or constricting the arteries is a way that it'll do it. When shock progresses, the body's defense mechanisms can no longer keep up with the problem. The blood pressure will fall. A drop in pressure is a late sign of shock, and it indicates critical decompensation phase has begun. A patient with low blood pressure, really low blood pressure, has inadequate pressure to maintain proper perfusion. What typically happens is they'll go unresponsive. When blood pressure becomes elevated above the normal range, the body defenses act to reduce it. The blood pressure, when would the blood pressure, give me an indication when you have really high blood pressure as a result of what type of injury? Petro. Blood pressure goes really high. Somebody tell me. What type of injury? Head injury. Very good. And then what happens is we have a narrowing of what that occurs. There's another indication. They call it the narrowing of the pulse pressure. That's the difference between the systolic diastolic pressure will start to come closer together. So you see a patient with 140 over 100 or 120 over 100. You're getting a trending effect where the pulse pressure begins to narrow. Measuring blood pressure. You have the diastolic blood pressure and you have the systolic blood pressure. The diastolic is the resting phase of the heart, what's when the heart's relaxing, and the left ventricle's at rest. And then the systolic pressure is increased pressure caused along the artery with each contraction, otherwise known as systole, and it's the ventricle. Systolic pressure is the max pressure that the artery is subjected to. Diastolic is the minimum amount of pressure that's always present in the arteries. Blood pressure is measured in millimeters of mercury, and it's reported as a fraction of the systolic pressure over the diastolic pressure. Obtaining blood pressure, we use a sphygmometer to do that. Here's an example of the pediatric, the regular, and the extra large. And we have the pressure gauge, we have the bulb. They all have to be working properly. And how we auscultate a blood pressure is we place these, place the cuff on the patient's arm. You want to make sure that that cuff is snug. It's not real loose. If it's loose, it's going to give an inaccurate reading. And then you want to palpate the brachial artery to make sure that you can feel the brachial pulse. And then you want to continue pumping until the you want to continue pumping until you have increase in pressure by an additional 20%, 20 millimeters of mercury. Auscultation. Note the systolic and diastolic pressures as you let the air escape. We all know how to do that. As soon as the pulse sounds, stop, open the valve, release the air quickly. It's very simple. Let's go back and we're going to watch a short little video. One more video. This will be on auscultation video. Give me the check mark when the video is done. Okay, that was a very simple thing on doing an auscultation blood pressure. I think no one will have a problem with that. No one has problems with that. Okay, you want to note the systolic diastolic pressures as you let the air out. As soon as the pulse drops, open the valve. Moving on. Palpating blood pressure. This is next. You want to secure the cuff. You want to locate the radial pulse, inflate the cuff to 200 millimeters of mercury. Some people won't like that. They'll tell you that the cuff's too tight. Especially in the older ladies, the elderly, they'll get very irritated about how tight the cuff is. The method only obtains a systolic pressure when you take an auscultated blood pressure. The back of the ambulance is probably a good time when it's on the road, traveling down the road, to take an auscultated blood pressure, because the fact is that sometimes it's very difficult to hear with the stethoscope. Let me go back and we'll show a short video on how to palpate a blood pressure. Give me the check mark when the video is complete. Okay, I'm palpating the cuff, secure the cuff, locate the radial pulse. What did they say differently than what this slide shows? Dan, can you tell me? I'm palpating a pulse. The slide shows when you inflate the cuff, you inflate it 200 millimeters of mercury. In the little video, what did they say? Hello? Can you hear me? Nate, can you help him? .30 above the pulse. Dan, are you with us? That is correct, Dan. Volume not working. Okay. Normal. Can you hear me, though? Dan, can you hear me? The audio?
I can hear you.
Okay. All right. Okay, normal ranges of blood pressure, adults 90 to 140 on the systolic. Children would be 80 to 110 on the systolic. That's 1 to 8 years old, and newborns would be 50 to 95. Okay, moving on. Next thing we're going to talk about is level of consciousness, which is one of the parts of the vital signs. Patients we use the mnemonic AVPU. Alert. V is responsive to verbal stimulus. P, responsive to pain, and unresponsive. Okay. Alert and awake. A, that signifies orientation to person, place, and time and event. So you want to ask the person their name, where are they, what time is it, what date is it, what month is it, what year are we in, who's the president, and the event. And then report it, and if they can answer all those questions appropriately, they're alert and oriented times 1, 2, 3, or 4, noting areas not oriented to. Then next would be verbal response. Okay, they respond to normal voice stimuli, they respond to loud voice stimuli, or they respond to finger tap if the patient is hearing impaired. And then next would be pain. They're responsive to pain. Use if the patient does not respond to verbal stimuli. Gently but firmly pinch the patient's skin to see if they react. Note if the patient moans or withdraws from the pain responsiveness. Then unresponsive. If the patient does not respond to painful stimulus on one side, try the other. If a patient who remains flaccid without moving or making a sound, they're considered unresponsive. So everybody got that on how to do AVPU determination? Okay, moving on. Pupils. This is a key vital sign, and what it does is it reflects the status of the brain's perfusion, oxygenation, and condition. The pupils will adjust in size depending upon the available light. If you put your hand over someone's eyes in bright sunlight and you look at the pupils and you block the sunlight out, the pupils will constrict. You remove your hand in front of their eyes, and as you're looking, their pupils will dilate. They'll become larger when light is available. And then when you darken it out, they constrict, they become smaller, and then you put the light in a dark room, they're going to be dilated. You put your pen light and they should react normally and start to constrict. And they'll constrict equally when normally appear in equal size. Depressed brain function should be assumed if the pupils react in any of the following ways. Fixed with no reaction to light. They dilate with light and constrict when light is removed. They react sluggishly. They're unequal in size, unequal with light, or when light is removed. Here's an example of showing you what constricted pupils are, as the top slide shows. Then the middle would be dilated, and then the bottom would be unequal. Okay, does everybody see that? The difference in the bottom one is unequal. Any questions? And we do carry pen lights on our apparatus, correct? Yes? Okay, good. And the other thing I like to think of is what I was taught is the pupils are the window to the brain. So if you remember that and you check someone's pupillary status, it kind of gives you an idea of the functioning level of their brain. Now the only thing to qualify this is if they have a history of cataracts. You're not going to get an accurate reading on that. In other words, you're kind of wasting your time if they have cataracts. Pupil assessment. You have pupils. We use the mnemonic PEARL, which is pupils equal and round, regular in size, and react to light. Pupils equal and regular reacting to light is PEARL. It's considered PEARL. Okay, next thing we're going to talk about is reassessing vital signs. On stable patients is every 15 minutes, and then on unstable patients it's every 5 minutes. I'm going to show another video, and give me the check mark when the video is complete. Okay, give me the rating on that video. It was kind of basic. No good? Okay. No good. It was a waste of time? Sounds like it. Alright, I'll see if I can find a better one than that. Alright, moving on. I believe that's our last slide. I want now, go ahead everybody, take out a piece of paper. I want you to jot some stuff down. We're going to do a little exercise here, and then we're going to be done. Okay, when you get a piece of paper and a pencil out, give me the green check mark to let me know you're ready to go. Okay, I'm still waiting for check marks from Petro, Nate, Lieutenant Tackett, and the guys that are gathered around the computer together. You can work as a group. Nate, Bob, are you okay? Okay, Nate found some paper. Now, if you have a pen, Nate, I'm not sure if you know what to do with it, but we're ready to go. Okay, this exercise, I'm going to give you a scenario. I'm going to read it to you, and then what I want to do is I want you to identify what the chief complaint is, and then I want you to give me some signs that's going to be indicated. I want you to give me symptoms as I read it. You want to write down what you think are symptoms, and then let me know what are anything that is most concerning in regards to the vital signs. Okay, then I want to know what your treatment plan is going to be. And I want to know what you think is causing the patient to be what you think is a problem in regards with the patient, and then what you can do for the patient to improve their conditions. And Nate, you have an X mark. Tell me what's wrong. Running out of paper. Okay. All right, somebody needs to give Nate a piece of paper. But anyway, you're ready to go. Here we go. Listen to this scenario. And everybody, I want you to write down as much information that I'll ask the questions. You ready? You respond to a man who is mowing his lawn around noon on a hot August day. Upon your arrival, you find a 54-year-old man who is complaining of chest pain and dizziness. You start a sample history while your partner obtains baseline vital signs. The patient states he has chest pain that radiates to the left arm and he feels nauseous. The patient looks pale and diaphoretic. The patient is not reproducible with palpation. The pain is not reproducible with palpation. The patient has no allergies, takes nitroglycerin for angina. The patient states that he did not eat today and only had a cup of coffee this morning. So far, your baseline vital signs include a blood pressure of 162/98, a pulse of 180, respirations of 20. Okay, follow-up vital signs. I'm not going to give you those now. So everybody got that? My first question is, and this will be for Jeff, and that will be for 10 points. What is the patient's chief complaint? Okay, Jeff said chest pain and dizzy. Okay, what is the most significant complaint that he's complaining of that we need to be concerned with?
Chest pain.
Chest pain. Chief complaint, chest pain. All right, next question, Petro. Does everybody agree with that? The most significant complaint that the patient has is his chief complaint. In this case, the patient was complaining of chest pain and dizziness, but the most significant of between the two is chest pain. So you're going to put his chief complaint down as chest pain, especially if he's telling you that it's radiating down his left arm and he feels nauseous. Okay, the next one, Petro, you ready to go? Give me what signs that the patient indicated in this scenario. Signs. In other words, something.
He was pale and sweaty, Mike.
Pale, diaphoretic.
Okay, that's it.
Dizzy.
Pale. Okay, signs would be pale and diaphoretic.
Yeah.
All right. All right.
10 points.
That's 10 points. Okay, the next. Taking a look at the patient's vital signs, okay, what would be concerning to you and why? And this question would go to Van. What is concerning to you in regards to his vital signs and why? And basically I'm talking about blood pressure, pulse, and respirations. Oh, what did he say? High pulse? Okay, I didn't see that. Okay, yes, that is correct. High pulse is concerning. The guy has a high pulse rate. His blood pressure, is he compensating with his blood pressure okay? Does everybody agree? Okay, he's compensating right now. But how long is he able to maintain that high heart rate? Okay, his respirations are within normal limits, on the high side of normal limits. His blood pressure is, I would say, could be normal for him. But his pulse rate definitely is elevated, so that would be something of concern to us. Okay, the next question would be, is Okay, what do you believe is a contributing factor to why he's feeling this way? Dan.
I'd say it was heat and exertion.
Okay, very good. Your patient was overheated from exerting. And what else is another contributing factor to this problem?
His age.
Age could be it. And
54 is pretty young.
Yeah. What was he doing?
Mowing the lawn.
Okay. What was his oral intake? If we looked at the sample.
He didn't. Had something to drink.
Coffee. What is coffee?
Caffeine.
And what else is it?
It's a vasoconstrictor.
It's a diuretic. So he drank coffee. He's exerting. Probably was sweating. So he's overheated and dehydrated. All right. All right. Let's get back to Jeff. What's your treatment going to be?
Aspirin and nitro.
Aspirin?
Nitro.
Okay, the patient says he doesn't have a history of heart problems.
Said he does have nitro.
You got angina.
I didn't say he had nitro, did I?
Yes, he did.
No, I didn't.
Yes, he did. He said he had
Yeah, because I wrote it down beside meds on the
nitro
sample.
because he has a history of angina.
Oh, let me read
Angina,
this.
he's going to have nitro.
Let me see. I'm looking at this.
Yeah, he said he had nitro and with a history of angina. Did that go through?
Hold on. Yeah, I hear you.
Yeah, it went through.
I said that? Oh, yeah. The patient has no allergies and takes nitro for angina. You're correct. Okay, so we're going to give him a nitro, help him self-administer a nitro. What else are we going to do? We're waiting for EMS.
Aspirin, O2.
Okay.
O2. Calm him down. Get him out of the shade.
Get him in the shade.
Nice cold beer.
Cool the guy down. Okay, we're going to do all of those things. Very good. All right, this concludes our, how long have we been on? Anybody tell
Hour
me?
and 49, 50 minutes.
Not the, okay. So we've
Yeah,
done
For
our,
about an hour and 25.
all right. That concludes Module 1. Everybody's gotten their CEU for it. You get a certificate in the mail.
Right.
Any questions? And I'm going to stop the recording, and then I'm going to, hold on a second. I'm going to pause the recording.